All right, everyone, we're going to get started. Everyone can take a seat. We're going to get started. This is the beginning of the annual research scholarship competition. Hey guys. This is the annual research scholarship competition. Oral presentations that are have already been reviewed and judged. At the end of these oral presentations, we will hand out awards to first, second, third place, and honorable mention. Have Dr. Steve Dominguez and myself, Anthony Dardano, we're both plastic surgeons, and we're going to moderate this session. And I'm going to hand it over to Dr. Dominguez to introduce the first speaker.
Good afternoon. I'd like to present Mr. Hamza Ashfaq from Pikeville, Kentucky. Speaking on cost comparison of endovascular versus open surgical revascularization in popliteal artery occlusive disease.
Good afternoon. My name is Hamza Ashfaq. I'm a rising fourth year at the University of Pikeville, Kentucky College of Osteopathic Medicine. And my mentor is Dr. Sibu Saha at the University of Kentucky, Department of Cardiothoracics. And I'd like to thank the college for giving me the opportunity to give this presentation. We'll be talking about the cost comparison of endovascular versus surgical revascularization in popliteal artery occlusive disease. First off, we have no conflicts of interest to report. The purpose of this study was just to really elucidate the cost differences between open surgical repair and endovascular repair in the treatment of popliteal artery occlusive disease. A direct comparison of these two procedures in the treatment of PAOD has not been explored before. Independently, they have been explored. So we aim to provide insight into those cost differences. PAOD is a vasculopathy that can lead to claudication and eventually extremity loss. Risk factors include diabetes, older age, male sex, dyslipidemia, and smoking history. The etiologies can be vaso-occlusive in nature or immune-mediated processes. Thromboangiitis obliterates specifically in smokers. Medical management is indicated initially. However, when that fails, endovascular repair or open surgical repair for persistent symptoms is recommended. That both have levels of evidence and CORs that are A and level 1. Choice is primarily determined by severity of the disease and the degree of involvement, including the distal branches of the femoral artery. So this was a retrospective analysis. We identified patients who underwent treatment for PAOD over a 6-year period at the University of Kentucky. We used the billing codes for both OSR and EVR procedures. The data was obtained for direct costs, including operating time, anesthesia, surgical services, supplies, and accommodations for both ICU and non-ICU rooms. As well as indirect costs. Indirect costs are those that can't be named directly, but usually include cost of staffing and suite maintenance for both the OR and the vascular suite. The test for significance we used was the May Whitney U test with the significance at P less than 0.05. In our cohort, we had 67 patients, 48 were male, 19 were female. The mean age was 59 years of age with plus or minus 12.1 years. 22 patients underwent OSR and 45 underwent EVR. Of the patients who went under EVR as compared to the OSR cases, they had significantly less days spent in the ICU, incurred less ICU accommodations costs, had less OR time costs and less anesthesia costs. Here's a further breakdown of our demographics. As you can see, the EVR group was younger than the OSR group at 58 years plus or minus 11.9 years, and the OSR group was 64 plus or minus 12.1. In terms of gender, we see that approximately the same, less than 1/3 in both ESR and OSR groups. Diabetes was more prevalent in the endovascular repair group at 64.4% versus OSR at 50%. And CKD was present in 22.2% of the patients in EVR and 9.1% in OSR. Not all of our patients were first-time recipients of an intervention for their PAOD. In the endovascular repair group, 17.7% of them had a previous ipsilateral bypass, and 28.9% had a prior ipsilateral percutaneous intervention. In the OSR group, it was 54.5% that had a prior ipsilateral bypass and 18.2% that had a prior ipsilateral percutaneous intervention. So within our OSR branch of the cohort, 59.1% received a FemPop bypass with a single saphenous vein graft. One only received a prosthetic graft, FemPop. Femoral distal bypass, 27.3% of those patients received that, and 9.1% of patients received a femoral distal bypass. Both of these last two were with a saphenous vein graft. Within the EVR group, almost all of them received the percutaneous transluminal angioplasty, 97.8%. There were 3 patients who received a thrombectomy, 3 who received a bare metal stent, and 2 who received a drug-coated stent, and only 1 with an arterectomy. As you can see, it doesn't add up to 100%, which means that there were a few patients who received more than 1 intervention. In this chart, we're comparing the length of stay and cost comparison between the 2 groups. So the significant difference was in ICU length of stay in days, as well as ICU accommodations costs in dollars. Open surgical repair usually had a longer stay at 2 days with a standard deviation of 2.5 compared to ICU length of stay in the EVR group at 1.6 days and a standard deviation of 3.8. ICU accommodations costs were more costly actually in the EVR group at $3,913 with a plus or minus of $1,681 compared to open surgical repair, which was $2,045 with a standard deviation of 2,777. Operating room costs and anesthesia costs, OR time was significantly different in the 2 groups. OR time was $3,000 and $3,019 plus with a standard deviation of $1,500, and endovascular repair was $2,149 with a standard deviation of $1,909. Anesthesia costs, we also saw that same thing with the OSR group being more expensive than the EVR group. And both of these were statistically significant, less than 0.05. So in discussion, anesthesia costs significantly higher in the OSR cases as compared to EVR. This might be due to the need for an anesthesiologist in the OR that's incurring more costs as compared to the utilization of a mid-level anesthetist in the endovascular suite. ICU length of stay and accommodations costs incurred significantly higher in OSR cases compared to EVR. This may be due to previous investigations have shown that OSR has low intraoperative complications. However, OSR cases are probably more have more comorbidities and are further along in their disease processes. There was a mistake on this slide that I only realized when I was rehearsing and didn't realize it over the last few months as I was creating this presentation. There was a significant difference between OR time costs of EVR and OSR, and for that the reason for that might be because of harvest time for the autologous graft. So this should be on the previous, second point should be on the previous slide. However, there was no significant difference between medical supply costs in EVR versus OSR. This is quite interesting because there's different evidence that shows that sometimes synthetic grafts are more expensive, sometimes autologous grafts are more expensive, and in general, EVR devices tend to be more costly. So and a larger sample size, maybe we could pick apart why or what the actual difference in cost could be in medical supplies. In conclusion, these results demonstrate that EVR is less costly intervention for the treatment of PAOD as compared to OSR. EVR should be highly considered in patients who are clinically eligible as an intervention of choice, and further investigation is needed for elucidating cost differences using itemized lists. It was just like to acknowledge Dr. Jonathan Davies, who collected the data for us. That's all. Thank you.
Thank you very much. Thank you very much. That's a very nice presentation and review. Does anybody have any questions?
Yes, I really enjoyed your talk. Question. How is that going to help in your practice? Like, well, if you make a decision based on how the patient is presenting to you, is that going to help you make a decision on what modality are you going to use?
So in reality, findings from this study shouldn't guide us clinically in deciding whether or which to use. In the end, it's up to the physician and the patient in terms of whether you're trying to, achieve alleviation of claudication versus limb salvaging. Like I said in the introduction, the choice is really determined by the severity of the disease. If there's a lot of the distal arteries that are in trifurcation, if a lot of those arteries are involved, then you have to do open surgical repair. At that point, you can't really fix it with EVR. So the takeaway from this study is just really what the cost differences are, not really a clinical guide toward which one we should use in terms of costs.
Thank you.
I saw on one of your slides that you utilized the billing codes to get the data. Did you actually look at the reimbursement, what the RVU or the reimbursement was for the procedure? Because that might add a little bit to the overall.
So this was a very simple first look at the cost differences. So that is something we will look in the future. But yeah, this is very, the generalizability of this is also very different from state to state and institution to institution as well.
I think it'd be a great second study to look at, get more numbers for this, and then next look at the reimbursement rates for them to see if there was any difference, because that would put together the whole look.
Yes, exactly.
Yes.
Dixon Santana from Lubbock. Good presentation, interest work. I was not clear if on the breakdown of all the patients that were selected for this analysis, what was the staging of their scheme? This is for occlusive disease. So you mentioned claudication, but then how many of those had rest pain, tissue loss? So did not disclose what was the runoff of those patients, and may have an impact on not only your selection, but the longevity of that repair that you do, either if it's endovascular or open surgery. In your data tends to suggest that younger patients might be better served with an endovascular approach as opposed to older individuals. Perhaps the reality tells you otherwise, where advanced stage patients, because of all their associated comorbidities, malnutrition, might be better off in initial endovascular approach because it's more invasive and it helps them to get back to the norm, as opposed to younger, which have a longer length of life, and therefore you would think that you offer a better solution with a better longevity. So can you comment on those?
So a couple of things. We do have another investigation looking at these clinical markers and stuff. I did say this is a retrospective cohort, but in reality it would be cross-sectional because we didn't follow them over time from their initial onset, when they first contacted our system, when they first got their first endovascular repair, because that's probably what they started with, and how they had progressed to eventual open surgical repair once endovascular had failed to alleviate those claudications or had just occluded to the point of requiring surgery. So that's one thing. We do have that investigation simultaneously running, and we should have that soon. The other question, that is true as the patients age and have more comorbidities, they're more likely to clinically require. It's a very intuitive relationship that they might require surgery rather than endovascular repair.
All right, thank you very much. Our next presentation is Nicholas Dimas, second-year medical student from the University of Kentucky College of Medicine. And the title of the presentation is Popliteal Artery Aneurysm Repair, a Single-Center Experience.
All right. Hi there, everyone. Is the mic good? So my name is Nicholas Dimas, working with Dr. Sibu Saha at the University of Kentucky College of Medicine. And our project was the retrospective review of popliteal artery aneurysm repair at the UK College or Medical Center. So just full disclosure, I did get I did receive a grant for a professional student research fellowship for working on this project. And then so a little bit about popliteal artery aneurysms. They are the most common peripheral aneurysm in the popliteal fossa, illustrated in the picture there. So the normal diameter of the vessel is about 1 centimeter, and it becomes an aneurysm when it's greater than 50% of normal, so approximately 1.5 centimeters. Open repair has been the gold standard for repair of these aneurysms, but new advancements have made endovascular a promising alternative for some of these patients who can't undergo open repair. And important to remember that these patients have other diseases. It's not just limited to the aneurysm itself. So just a little bit about how they form. Due to loss of the mechanical integrity of the vessel wall, this could be due to things like inflammation, genetics, or hypertension and trauma. So all the patients in here either had a true aneurysm that involved all 3 layers of the vessel wall, or a pseudoaneurysm that only involved 1 or 2 of the vessel layers. And then some of the risk factors are smoking, hypertension, obesity, and advanced age. These aneurysms are more common in older males, typically older than 65. They do occur in females, just not nearly as common. And when these patients present, they can be asymptomatic, or they can have some of these lower limb ischemia symptoms. I learned as the 6 Ps: pain, pallor, paresthesia, paralysis, pulselessness, or poikilothermia. They may also have non-healing ulcers on their foot, or a blue toe syndrome illustrated to the side there. And we group the patients either into acute or chronic limb ischemia when examining them. So acute less than 2 weeks, or chronic over 2 weeks of these ischemic symptoms. And it's not uncommon for patients to have bilateral aneurysms. Like I mentioned earlier, for the diagnosis, the diameter is about 1.5 centimeters. You can palpate the fossa to try and find the aneurysm, but I'm sure a lot of you may know palpation may not always be the best thing for detecting smaller aneurysms. So things like duplex ultrasound or a CT or MR are more commonly used for diagnosis. And you can also use things like an ankle brachial index or ultrasound to evaluate the degree of claudication downstream from the aneurysm. So repair is indicated for all of these aneurysms regardless of their size, if they are symptomatic or if they become greater than 2 centimeters in diameter. If they are asymptomatic, you can go more conservative with medical therapy and then just survey them to see if they do grow to that size criteria. It's when they get symptomatic that you start thinking about, is it open or endovascular repair time? But the main goal is always to minimize the risk of limb loss, which I'll talk about more later. So we wanted to compare the outcomes of these 2 different techniques over a 10-year span. We looked at post-op complications, reoperations, the average hospital length of stay, and the long-term patency for these grafts. So charts were reviewed from January 1st, 2010 to December 31st, 2019. The open repair grafts utilized either a Gore-Tex vascular graft or a vein conduit. This was usually a greater saphenous vein from the patient's lower extremity. And all patients were diagnosed with either a popliteal artery aneurysm or pseudoaneurysm. these pseudoaneurysms were confirmed via histology. And graft patency was assessed at these follow-up visits through pulse palpation in the lower extremity, ABIs, and arterial duplex. So over this 10-year span, there were 72 total repairs done, majority males. Average age was about 63, kind of wide age range there, 22 to 89 with one very young outlier at 22 years old. But majority of patients presented with acute lower limb ischemia lasting like less than 2 weeks, excuse me. These were usually emergency cases. They presented to the ER, and a smaller subset with chronic ischemia over 2 weeks. And then 6 of these, total 72, were diagnosed as pseudoaneurysms, and 11 patients had bilateral aneurysms, so that accounts for 22 total out of the 72. In majority of these were diagnosed using a CT, remainder ultrasound or X-ray. So comparing the two different techniques between the groups, thankfully they were pretty even between 237 endovascular versus 35 open. Endovascular was used for a little bit of a older patient population, 68 years old there. They were also used for a couple more asymptomatic patients, 7 versus the 2 in the open group there. And then also note that in the pseudoaneurysm case, the open repair was used more commonly for 5 out of those. And a majority of the open repair cases utilized vein conduits using the greater saphenous vein. Only 2 utilized corticus grafts. So once you get into the post-operative outcomes, this is for 30 days. Endovascular repair was on average shorter length of stay by about 4 days. It wasn't statistically significant, but 4 days still is a pretty good amount, especially for the patient. I will note there were 2 post-operative deaths within 30 days in the endovascular group. These were due to, one was due to an acute kidney injury and NSTEMI, sorry for the typo on the bottom of the slide there, should be NSTEMI, and the other was due to a respiratory failure. And then amputations or reoperations, I'll talk more in detail about in my next couple slides, but similar rates between those two, and also similar rates for patients who were still hospitalized within 30 days post-op and who were also followed up in clinic. So looking at the less than 30-day reoperations, majority of the open repair were actually done for hematoma evacuation, which makes more sense considering the nature of the open repair surgery. And then endovascular repair had more fasciotomies and angioplasties for the stents. And then there were patients who had multiple operations, as I broke down there, or just had a single reoperation. And there were 7 total patients who required multiple reoperations over the 30-day time. So once you look into the amputations between the 2 groups, there were a couple more in the endovascular group, in the less than 30 days group, and all the way out to 90 days post-op. It's not until greater than 90 days post-op that open repair had just 1 more amputation. The amputations mostly involved above the knee, as you can see there for the endovascular group and the open repair group in less than 30 days. And then also involved the knee as you get to that kind of intermediate follow between 31 to 90 days. And there are also a couple amputations involving the toes and the forefoot as well for these. So once we start looking at the follow-up date for how well are the grafts actually working, how patent are they, you can see a lot of the endovascular group less than 30 days, they were asymptomatic when they presented back to follow-up, and that was judged based on those symptoms I talked about earlier, the 6 Ps. And there's pretty much a 50-50 split in the open group. But good news is 100% of grafts were patent in both groups at that less than 30-day follow-up. Then once you start getting to the 31 to 90 days post-op, that's when graft patency kind of falls a little bit, 75 versus 85% in the open group there. So a little bit higher in the open repair group. But no really significance there or presenting symptoms. And then even longer term, greater than 90 days, graft patency kind of falls off a little bit more there, 72% in endovascular versus 82% in the open repair group. We'll note that there are a couple more patients who are asymptomatic in the endovascular group there. And then some patients we had no recorded follow-up data on in our medical record. It was 7 in the endo group and 6 in the open repair group. So once we start looking at even longer over time for greater than 2 years post-op, Pretty even number for comparison between the two groups. The majority of patients in both groups were asymptomatic. And then graft pain C was a little bit higher, actually, 81% in the endovascular group compared to the open repair group. And if you look on the chart to the right there, I plot them out over time from days post-op, with open being the red line and endovascular being the green line. So overall, pretty successful graft pain C over time for the two groups. So what conclusions can we draw from this? Is that endovascular is a promising alternative to the open repair group, especially if you're looking at the average length of stay, 4 days shorter for the endovascular group on average. It has similar results to the open repair group, and it could be a really good alternative for patients who don't have good vein grafts, or you don't want to put them through the extra stress of open surgery. But open repair may still be preferred in some of these more emergent cases, or in the pseudoaneurysms where most of those were repaired using the open technique. But further studies should definitely still be done, considering the size of our cohort we had here. So just some limitations with it. It was a retrospective study of a single medical center. Our sample size was 72 patients over 10 years. This isn't a really common condition, but it is still very serious, as you can see from the high number of amputations that happen even after repair. And then there's also some operator bias, which surgeons were on call that day, which one is actually doing the surgeries. Do they have a preference for one technique over the other? Thank you guys so much.
Thank you, Nicholas, for your nice review of popliteal aneurysms. I'll open the floor to questions, please.
Great presentation, Josh Holland from Omaha. I haven't done vascular surgery in a really, really long time, since I was what I said. But this question is partially from my ignorance. What was the driver of length of stay? Because obviously there's length of stay difference between the endovascular and the open repair. Why are you staying in the hospital at all? Is that mostly pre-operative stay? Is it post-operative stay? And what's the driver?
Post-operative stay, like I said, some of them do have these other coexisting conditions, so a lot of them want to be followed up, make sure they didn't have anything else that could have happened, and with the high number of reoperations, some of them did have. Good afternoon, thanks for having me, and yes, another Kentucky presenter. So I'm just going to talk about our experience with cannulation strategies with oxygen-med ECMO support in patients with end-stage lung disease. I don't have any relevant financial disclosures. Brief historical perspective. So Dr. Bartlett kind of pioneered ECMO use in the United States. It was actually an early randomized trial in 1979 that kind of blunted the interest in the therapy for adults with respiratory failure due to significant mortality and morbidity. But it still went on to create the ELSA organization in 1989. In 2009, they had another RCT, the Caesar trial, that again was kind of underwhelming for the benefits of ECMO. But then around 2011, with the H1N1 flu pandemic, we saw a pretty stiff increase in use. The Eolia trial in 2018 did kind of support early intervention with ECMO in severe ARDS. And then, with the last 3 years now, COVID pandemic, we've had a pretty robust experience with ECMO support of these patients. Briefly, end-stage lung disease, a wide variety of pathologies can lead to it. Lung transplant is the standard of care, end-of-line therapy for these patients. COPD, interstitial lung disease, cystic fibrosis, and pulmonary arterial hypertension are your primary drivers there. I'm not going to talk about COVID that much, but the pathology of it in COVID ARDS is it creates an anatomic shunt and reduction of your functional lung size. So we've actually been able to develop, all across the country and the world, a lot of data regarding VV ECMO. And it's notable that with this shunting and then even with ECMO support, a lot of patients can progress to right heart failure. Which brings you to the oxy-RVED. Essentially, you're combining the oxygenation and ventilation support of VV ECMO with right heart support by returning the blood directly to the pulmonary artery. Cannulation is generally peripheral, but can be direct central cannulation. you can actually continue the RVAD support without oxygenation if the lungs improve, but they still have right heart failure. The basic configuration strategies, traditional tube cannula, most often that's going to be right femoral drainage, or femoral drainage cannula and IJ return line. More recently, some dual lumen cannulas, especially the Protect Duo, have been able to progress to using one cannula in these patients. And central cannulation would be via the main PA and right atrial or femoral vein drainage. Just some pictures. So, all from patients that we took care of. Two cannulas. So this is a left IJ return, see across the lumen line, and then a right femoral drainage. Just the opposite here. So right IJ return and a left femoral drainage. This is a not great picture, but you can see how bad this person's lungs are. The Protect Duo come in via the left IJ, so they only have the single cannula coming up. You can kind of appreciate that there's an inflow and an outflow here in the proximal part of the cannula. And then the crescent here isn't technically a dual lumen, but does provide a kind of directed return as a little outlet here that can directly return to the tricuspid valve and theoretically get a little better heart function with it. And then just central cannulation is very uncommon that you would do central oxygen-RVAD cannulation for someone without being on their chest already. So this is usually for patients who we've already done a lung transplant on, and we use ECMO to support them during the case. Just leave it on there for a few days until you can decannulate them. So for our experience, the data collection kind of started in March of 2021 to June of last year. We had 29 patients that had acute respiratory failure that continued to decline on maximal ventilatory support. All were placed on VV ECMO and then subsequently required right heart support as well, so advanced to an oxy-RVAD configuration. COVID was the primary driver of these patients. We had 20 patients with COVID, ARDS, 4 patients with just interstitial lung disease, 2 co-workers pneumoconius. This patient was actually kind of a unique group that we deal with, still around. And then 1 parainfluenza patient. 8 of the patients went on to have successful lung transplants. 7 of them were bilateral lungs. 1 was a combined heart and lung. Did note that 16 patients expired during evaluation or were deemed non-candidates, or family decided to withdraw care. And then 4 were actually weaned from ECMO and decannulated. 1 that did have a transplant, but it was at an outside institution. We had to transfer them to the Canadian lung and kidney. So for the configuration strategy, most often we would start with 2 cannulas off on the right IJ, right femoral. The brand Biomedicus is just the institutional preference here. But we try to advance patients to the Protect Duo single cannula, single dual lumen cannula towards as they got closer to being looked at a transplant, because you could go with single cannula in the right IJ and then they could walk around and participate in physical therapy to be an important part of getting them prehab for transplant. 31% of the patients that we talked about made it to transplant. 14% were able to be weaned off ECMO. And then we had a 55% mortality, which is kind of consistent with mortality in severe ARDS cases, which holds a baseline very high mortality rate. And then once you have right heart dysfunction, on top of that, some studies cite up to a 90% mortality. So our institutional goal has been to identify right heart dysfunction early, advance patients to an RVAD configuration if it's deemed appropriate. We do this by generally having bedside echoes done about every 2 weeks or so, or sooner if there's other reasons to think that they're right heart is starting to fail on. From our experience, we did deem that oxygen ECMO support is a reasonable treatment approach to patients with end-stage lung disease while they're undergoing evaluation for or awaiting lung transplantation. We do actually have kind of an increased usage of femoral drainage in our sicker patients early on. And then, like I said, we try and progress to a single dual lumen cannula as they get closer to the operative period, just to facilitate rehabilitation. You have to note these are very sick patients. The oxygen really is just buying the time to sort out other issues that may be keeping them from being listed for transplant or being considered appropriate for transplant. It doesn't really do that good a job of resting the right heart, so you're not necessarily recovering it until you can take care of their underlying pathology and get them new lungs. I just want to briefly acknowledge Dr. Krishnamurthy, Dr. Malayala, our UK ECMO specialists, and all the TV ICU staff that help us keep these patients going day after day.
Thank you. Very nice presentation. Thank you. Questions from the audience?
One comment that it's a smart idea to do federal because when it's cheap and you can do it at the site with no other drawback later on because it's central protector which is like 3,000 for cartilage itself. And the question is, what was your survival for all the COVID patients? How many did you do? I know this didn't involve all the COVID patients.
Yeah, just as in COVID patients that went on ECMO.
Survival, to recovery and transplant.
I think our ECMO survival rate for COVID patients hovered around 50% kind of throughout the whole pandemic period. I mean, obviously everyone with COVID was quite a bit higher than that.
Are there any predictors that you guys found just after reviewing all this that would make you want to do earlier cannulation versus not?
That's kind of briefly talked about. We did start doing more frequent bedside echocardiograms just to assess the right heart function because I think earlier on we were getting caught off guard by sudden decompensation in patients that otherwise we thought were fine because they're on standard VD ECMO, and then the right heart's failing without really knowing. So that became more of a screening tool rather than us trying to react to it. So that helped us out. I think that probably at least the last year or two.
So instead of being reactive, you think you could react?
Right. Trying to be a little more proactive as they start to see higher PA pressures or right heart dilation, anything like that. And then we started talking pretty early about switching to an oxygen.
In your patient population, your opinion, was the COVID-induced cardiomyopathy a contributing factor, or was it just incidental? Not at all.
I think it was more reactive to their underlying lung disease. Didn't see a lot of, you don't really see like left heart failure or anything like that. It's pretty confined to the right heart as they've been on ECMO or been on the vent for a couple weeks, something like that.
Thank you very much.
All right, thank you. Our next presentation is Dr. Ivan Rodriguez from University of Colorado, Natural Medical Campus. And the title of the presentation is Whole Blood Resuscitation Following Liver Transplantation. Is it time for implementation?
Good afternoon. Thank you to the U.S. chapter of the International College of Surgeons for the opportunity to present our research exploring the use of whole blood resuscitation in liver transplantation. My name is Rodriguez. I'm a research fellow at the University of Colorado in the Division of Transplant Surgery. We have no complex to disclose. There's 3 facts that every transplant surgeon has to deal with every time they take a liver transplant recipient to the operating room. First, due to both recipient and donor characteristics, as well as the extensive nature of the surgery, coagulopathy during liver transplantation presents a dynamic challenge in resuscitating patients during and after surgery. Second, despite advances in preoperative optimization, surgical techniques, and real-time coagulation assessments, massive transfusion during liver transplantation remains common. Finally, and perhaps addressing the elephant in the room, blood transfusions are independently associated with both graft and patient survival. The coagulopathy of liver disease was identified by Dr. Starzl as a major cause of morbidity and mortality since the very early days of liver transplantation back in the 60s. It is routinely measured in real time by viscoelastic assays such as TEG, and attempts to correct it lead to massive blood clot revitalization. But why does it happen? End-stage liver disease causes profound derangements in coagulation homeostasis through a variety of factors. It decreases the concentration of almost all procoagulant factors, and at the same time, the concentration of anticoagulant factors produced by the liver are significantly decreased. It leads to endotoxemia and nitric oxide dysregulation, causing profound endothelial dysfunction, which in turn leads to both localized hypo and hypercoagulable environments. It also results in decreased clearance of tissue plasminogen activator, or TPA, as well as an accumulation of plasminogen activator inhibitor, or PI1, which are the major regulators of fibrinolysis. So it really affects this balance between degrading clot and not. But why whole blood? Why are we advocating for it? Well, after a decrease in its use following its peak in World War II, initially due to crystalloid therapy and subsequently due to component therapy resuscitation, whole blood resuscitation saw a resurgence in the 1990s, spearheaded by the military for its usefulness in austere and forward operating environments, based in part due to the events during the U.S. intervention in Somalia, where an unfortunate young Marine was the victim of a shark attack, for which a massive response was done in base to accumulate whole blood. Unfortunately, this Marine passed. All this whole blood was restored, and this just happened to be several days before the events depicted in the movie Black Hawk Down, where the operation did not go as planned, and we were not really prepared for it, except for this excessive amount of stored whole blood that they had and were able to implement and further publish these results. The civilian world took notice of this, and trauma centers across the country started introducing cold stored whole blood into their trauma response algorithms. Flash forward a couple of decades of experience from both environments, and data showed that whole blood resuscitation reduces antigen exposure and decreases costs compared to blood component therapy in massive bleeding. More recent studies also show reduced need for non-therapeutic fluids, which can lead to subsequent dilution, coagulopathy, as well as acidosis, which is preventing this is especially important in patients who are fluid balanced, fluid shifted, such as those with end-stage liver disease. So, okay, whole blood resuscitation has some well-described benefits in trauma, but how or why would we apply it to transplant surgery? To start with, in our institution, our liver transplant surgeons use an average up to 8 times more blood product per year when compared to our trauma surgeons. So kind of really brings into perspective who should really be advocating for this when trauma has been the ones that have been leading the charge. I think we, in our field, we could definitely have some introspective and push this a little forward. Also, as previously reported, whole blood and liver transplantation is equally effective and potentially safer. In part due to the fact that reduced number of donor exposures can reduce the risk of infection transmission, which is especially important in this immunosuppressed population. Additionally, using whole blood instead of multiple components can simplify the handling, preparation, verification, and transfusion procedures, especially in very crowded and busy OR when anesthesiologists are trying to catch up with the patient's resuscitation. So with these arguments, we sought to study how we could potentially introduce this in our institution in an effective and, importantly, reproducible way. So looking at previous data from our quality improvement work, our group developed a score to risk stratify patients for post-operative needs 2 hours following graft reperfusion in liver transplant. This scoring system enables surgeons to risk stratify the probability of requiring ICU care and provides guidance for patient disposition from the OR, including blood product utilization. With this, considering the profound coagulopathy that some liver transplant recipients experience post-operatively, the objective of this study was to investigate whether the patient post-operative disposition score can be used to identify those who would benefit from whole blood resuscitation. We hypothesized that this disposition score could identify patients that would benefit from whole blood resuscitation. To achieve this, adult liver transplant recipients were preoperatively enrolled to collect perioperative transfusion data. All patients were transplanted at the University of Colorado Hospital, which averages over 100 liver transplants a year. Liver transplant patients were stratified into 5 groups based on their disposition score, given at 2 hours post-reperfusion. We equated 1 unit of whole blood to the combination of one unit of RBCs, 1 unit of plasma, and 1 unit of platelets. Patients were evaluated for total transfusion requirements up to 12 hours following the time of scoring. The percent of patients that would have received at least 1 cooler of whole blood during this time frame were identified per cohort, in addition to the number of donor exposures, as well as estimated blood bank costs per patient. With this, a total of 275 patients were included in our analysis. Based on their calculated disposition score, 12% fell into the PACU-4 category, 36% fell into the PACU versus extended stay category, 31% were directed towards extended stay, 17% fell between extended stay and ICU, and 4% were assigned to the straight to ICU pathway. So how does this pan out with our analysis? When contrasting the disposition score to blood product utilization, the score successfully stratified patients in median red blood cell unit utilization, where those with a disposition score of 0 required 3 units of RBCs in an average, which increased to 7, 11, 19, and up to 28 for those with a disposition score of 4. This also mirrored the calculations of whole blood cooler utilization, with 23% of those with a score of 0 requiring at least 1 whole blood cooler, increasing to 47, 64, 83, and 93%, up to 93% in those with a score of 4. Next, we contrasted this disposition score to the number of blood donors that these recipients were exposed to. And we can see the significant potential reductions in exposures in using whole blood in the grid bars in green. We also looked at costs based on our blood bank pricing data, which on the right side of the slide, you can see the estimated decrease in these of using whole blood over conventional component-based resuscitation per patient. In summary, whole blood has demonstrated advantages in the resuscitation of trauma patients when compared to component resuscitation therapy. Coagulopathy is a major hurdle to overcome in the treatment of liver transplant recipients. Quality improvement derived pathways, such as our disposition score, can help predict transfusion needs. And finally, whole blood resuscitation can reduce the number of exposures as well as costs associated with massive transfusion in liver transplantation, while being equally effective and perhaps having a safer profile. In conclusion, whole blood has a potential role in resuscitating massive bleeding in liver transplant after reperfusion to reduce antigen exposure and cost. Liver transplant recipients with a disposition score of 2 or greater are the most likely to benefit from this resuscitation strategy. With that, I would like to thank my mentors, co-authors, and the rest of the transplant team at the University of Colorado, and I'm happy to take any questions.
Thank you. It was an excellent presentation. Appreciate it. To the floor for any questions.
Great presentation, great work. Can I just ask some questions about your whole blood program? To me, this makes total sense. It makes blood resuscitation much more simpler. But are you using cold-stored O positive whole blood? And what do you consider low titer? How are you assessing that? And how do you develop your donor pool for this? Is this piggybacking on the trauma? How does this work?
Yeah, so this is all theoretical in the transplant world. This is an exploratory study of what results we would anticipate and how we would implement it. But we are piggybacking on the results from our level 1 trauma center in their application of whole blood. It's O positive whole blood for the most part. Based on data and to having obviously O recipients, but also we anticipate A recipients having acceptable outcomes in unit B. In terms of expanding that to other blood types, we are in discussions with our local blood banks to establish a pathway for our donors to be able to plan ahead and be able to acquire blood types for those type of donors, but it's nothing it's actually not been established yet.
Thank you.
So I have a question about whole blood availability
Right.
compared to other components. Is it harder to find whole blood for the blood banks?
Yes and no. It really varies a lot, and whole blood has some advantages that our blood bank is able to share. For example, when we have a level one trauma activation, if a cooler is not used within a specific time frame, it is able to be brought back into the pool and then be able to use by other services. This doesn't necessarily happen with other services. But what I'm trying to get at is it depends on how busy trauma was that week.
I mean, theoretically, it should work because we don't bleed just platelets. We bleed
Right.
blood.
Right.
Okay, next.
One quick question. Hey, nice presentation. Mayor Ryan from Robert Johnson University. What's the routine use of viscoelastic gravity in transplant patients? My understanding is that the transplant folks still have a law on the use of rotent or tag, at least universally.
The use of quantum.
The rotent or tag.
Right.
So do you think we're heading in that direction to guide some of the intraoperative resuscitation? Your thoughts?
Yeah, I definitely think we're headed in that direction. Our institution is very tag heavy. We do have rodent, but our practice is more reliant on the traditional tag 5000s, and more recently we're working in implementing a newer version of the tag, the tag success, and having it actually in the operating room where anesthesiologists are able to hand over the sample to a tech that's right there in the room with them and get a more direct result instead of having to send out the sample, call the bank and see what the result was and then act upon it. So I think as a field, yes, in general, we're headed in that direction. We're definitely trying to evangelize in that sense for sure, but I think not all centers are implementing it. And in terms of whole blood use, like very limited use. This data, the study that we presented was 20 years ago out of UCLA, and since then no one else has really published on it.
Thank you very much. We're looking forward to your sequential presentation in a couple of years.
Yeah, thank you.
Next, I'd like to introduce Dr. Rachel Schneider with an evaluation of post-operative urinary retention and transabdominal pre-peritoneal inguinal herd repair challenges and chart.
Hi, thank you so much for having me. My name is, Hi, thank you so much for having me. My name is Rachel Schneider. I'm a rising fourth year medical student at the University of Massachusetts. and today I'm going to be presenting on the evaluation of postoperative urinary retention in patients who have undergone transabdominal preperitoneal inguinal hernia repair. I have no financial disclosures to report. So postoperative urinary retention is simply the inability to urinate after a surgical procedure, typically with around 600 milliliters of retained urine, which requires catheterization, and this is readily diagnosed by ultrasound. Anesthesia and opioid pain medications can relax the smooth muscle, which can make it more difficult for the bladder to function normally. Additionally, intraoperative fluid can cause bladder distension. And the overall incidence of POR is around 5 to 70%, depending upon where you look in the literature and which study you're reading. As you can see, this is a very variable statistic, and vague diagnostic parameters and variability in data collection create challenges in estimating the true prevalence of this problem. Some of the risk factors for POR include male sex, increased age, increased BMI, benign prostatic hyperplasia, general anesthesia, and pelvic surgery. Some of the risk factors for developing inguinal hernias include also male sex, increased age, increased BMI, and BPH. As you can see, there's a lot of common risk factors for POR and for having an inguinal hernia that requires TAP. And that's why we decided to look at TAP patients to evaluate the incidence of POR. And POR can occur after TAP between 0.2 and 35% of patients, again, depending upon which study you're reading in the literature. So why is this important? As we've spoken about, TAP patients are at high risk for POR, and there's a highly variable incidence in the current literature, making the true prevalence difficult to determine. And POR can increase pain and increase the risk of emergency department visits for post-op patients, urinary tract infections, and other post-operative complications such as nausea and vomiting. And overall, this can increase the length of stay for patients and also increase hospital costs overall. So for this study, we used Epic Report Workbench and Slicer Dicer, which are two tools in our EMR, and we identified around 3,500 patients who have undergone TAP in the last 5 years. This is a picture of the report that we generated. As you can see, we could choose the surgery dates, the primary procedure, and the diagnosis codes that we wanted to include. And here are some of the additional variables that we included in our report. So we included ICD procedure codes, diagnosis codes, and problem list codes as well. So using Epic Report Workbench and the problem list diagnosis codes and ICD codes that fit our criteria for POR diagnosis, we only found 6 patients, so far under 1% of our population of TAP patients that would fit our criteria for POR. And then using Slicer Dicer, we broadened this criteria to include patients who had POR within 6 months of the procedure. We did this because we wanted to include patients who were diagnosed with POR at a separate encounter than their hospital encounter for their operation, such as patients who were discharged and returned to the emergency department for urinary retention. And we still found far under 1% of our total population that was fitting our criteria for POR. This is a table showing some of the ICD codes, diagnosis codes, and problem list codes that we used to query our population for POR patients. So we thought that this was really an underestimation of how many of our patients had POR after TAP, and we wanted to do a manual chart review to check this. So we decided to create a random sample of this larger population to do that manual chart review on. And we used this formula to determine the amount of patients that we would need for that sample size. We came out to around 95, which we then rounded up to 100. So in this formula, the z-squared is the critical value, p is the true probability in our TAP patients of having POR, and n is the number of our patients who underwent TAP. So we chose 0.1 or 10% for the true probability of developing POR in our TAP patients. We chose this because, although it's very variable in the literature, most of the papers that we were looking at had an incidence of under 10%. And the closer that p-value is to 0.5, the more conservative the estimate for the random sample is. So we wanted it to be on the higher end of what we were seeing. So we used 10% to come out to around 100 patients needed. So we then used data to create a random sample of our population. And we extracted the MRNs of these 100 patients and manually reviewed the selected charts. And in the chart review, we checked every post-operative note for mentions of POR, including mentions of bladder scan volume. We found that 6 out of our 100 patients for manual chart review met our criteria for POR. So 3,500 patients underwent TAP in the last 5 years. And when we were using the typical tools that we would for chart review, such as Epic reporting or Slicer Dicer, this didn't identify many patients at all that had POR, less than 1%. However, when we had manual chart review of our random sample, we demonstrated POR in about 6% of our population, which is much more in line with anecdotal data and literature. So this really underlies some challenges in diagnosis of POR. As I mentioned earlier, typically 600 milliliters is the benchmark for postoperative urinary retention, although some papers cited 200 milliliters of urine considered to be abnormal. So as you can tell, there's some variability in diagnostic parameters. Additionally, the physical exam and bladder scan can overestimate bladder volume. And there's also some physician bias when diagnosing POR. Physicians may be more likely to look for POR in patients that they know are more predisposed to it, such as older male patients with BPH, and may not be as prone to look for POR in patients like young females who are less likely to develop it. Additionally, this really showcases challenges in chart review. So if the diagnosis code is not listed or the ICD code is not recorded, it's not something that's able to be tracked long term. And then even with our granular chart review, notes are often incomplete or vague, and volumes may be recorded in resident handoffs or in Epic chats, which are a secure chat function that's used between nurses, PAs, doctors, and other members of the healthcare team. And these are not kept in the charts, and so they can't be reported on. So this was a low-powered study. The sample size calculation also required some assumptions of the true probability in the population, which was unknown. Additionally, random sampling always risks not being representative of the population as a whole, especially because we only took one random sample. In our institution, practices may not be generalizable to other hospitals, especially at institutions that don't use Epic reporting. So we identified a high level of variability in identifying POR via Epic reporting. Manual chart review seemed to be much more accurate in identifying instances of POR, and more consistent needs of documenting POR after TAP are needed. Ways to have more standardized documentation of this could be to encourage adding POR to a problem list. Additionally, emphasizing that narrative notes are really hard to capture when doing data analysis, and verbal orders and Epic chats are not useful for monitoring patient outcomes long term. So POR can increase length of stay and hospital costs. It can also cause patients pain and increase the incidence of urinary tract infection and other complications. It needs to be tracked more efficiently to identify and mitigate the risk to patients. And from a quality perspective, this is a really common problem post-operatively, and this chart review showed that it's very difficult to track when it's hard to diagnose definitively and often is not recorded as an official diagnosis in the patient's chart. And we need to have a better understanding of the breadth of the problem before we can have preventative efforts to improve patient outcomes. So before I move on to questions, these are my references. And thank you all for listening, and I wanted to give a special thanks to my mentor, Dr. James Carroll, and the UMass surgery faculty for helping with this research.
Thank you, Rachel.
I've got some questions first before. So, was this dependent at all on your study findings on the length of time of the patient being on the table?
So, we did not find that it tended to be dependent on that. We're working on another analysis that looks at the factors that are significant for POR at our institution. Certain things that we were looking at were lengths of operation, laterality, and also the different anesthetic agents that were used. That's still not finalized research, but we weren't seeing right now that the length of time had any significant difference, but also the length of time for TAP procedures seem to be fairly uniform. So I'm sure for other procedures that are not TAP procedures and for surgery in general, I think that the longer the operation is, there may be an increased risk of POR. However, a lot of those patients also start to have Foley catheters during the operation, which can mitigate that risk as well.
Very good insight. The other question I had was the amount of IV fluid, TAP fluid that was used, and whether they had intraoperative Foley versus non-intraoperative Foley that might influence your poor results. And also, what length of time was that Foley, if present, removed in the PACU, or was it done in the OR?
So for our patients for TAP, we don't typically use a Foley catheter. I'm not sure the amount of IV fluids. That would be a really great thing to add to our research going forward. I think a lot of this research showed us that these are really important questions, and it's really difficult to ask them when we're not even sure how many patients are having postoperative urinary retention without a really granular manual chart review. So I think next steps would be having that granular chart review out of larger population than just our 100 random sampling, and during that looking and drilling down into the type of anesthetic agents used, the amount of IV fluids, time in the PACU, variables like that.
One more before you go to the floor. These are type of anesthetics, are you meaning general versus spinal? And if so, was any local anesthesia used in any of your cases? I didn't see that you mentioned if a local block was given, a regional block.
I don't think that regional blocks are typically given except for at the incision sites, just at the port sites. I think, forgive my pronunciation, Sumadex was one of the agents that one of our anesthesia residents was interested at looking at, seeing if that improved the incidence of POR, because he was under the impression that more patients seem to have better outcomes with that anesthetic agent.
Floor.
Two questions. Number one, why did you give them 6 months afterwards to present to the emergency room with urinary retention to include? I mean, if this was going to be an operative thing, I would say if you go home and you can't pee within 24 hours, you're going to be back. And you pointed out, especially with your with people at risk, are going to be older men with prostate issues. So you might be doing a hernia repair on somebody, but they may turn up 3 months later in the ER with urinary retention. And I'm not sure you want to necessarily assign that to your operative thing. So that's one thing to just think about. Was there a reason you picked 6 months as a time?
Yeah, that's a great question. So definitely patients that were post-operatively presented to the emergency department would have presented far quicker than 6 months. I think the idea behind that was that we wanted to also capture clinic notes if patients were complaining that they were not able to completely void afterwards. And if we had had a high number, we wanted to look back through those patients and see, was this related to their operation or not? But at that point, we were really saying, we're finding barely any patients that are meeting these criteria. Even if we stretch it that far to capture anybody that could possibly have this documentation in a clinic visit, and, I think 6 months was probably a little bit too far to look, but that just kind of showed us that globally, at least at our institution, this is really not something that's being documented well at all, because that should be capturing even extra patients that maybe had urinary retention not related to their surgery, and was still capturing a very, very small percentage of our patients.
Question number 2 is, were these people on like some kind of fast track to get them out of the hospital?
I don't believe that they were. I would have to look through their charts, and this is over 5 years. But typically these patients, stay in the PACU until they're able to void, and then they're sent home within the same day unless there's some other complication or need to be watched overnight. But I don't think that there's a specific fast track that they're being put on.
Because the thrust of the question doing thoracic surgery and people who have thoracic epidurals and whatnot, like you pointed out, trying to define urinary retention is a slippery character, because sometimes the nurse will call me at 10 o'clock at night, oh, Dr. Pikeville's here, basically urinated, you know, in 8 hours, the bladder scan shows 400. And instead of dogmatically saying, well, he's met time or he's met volume, I said, well, how's the patient? Well, patient's pretty comfortable. Well, give him a few more hours, see what happens, you know, or, oh, patient's really uncomfortable. Well, then, you know, so it's kind of a hard endpoint to pick. And when people who you've done a procedure on and are sitting in the back of you and, you know, the clock's running because you're on a fast track to get them out, I'm just wondering if that changes your threshold for how you're defining urinary retention, because you just want them to pee and go home.
Mm-hmm.
So you don't have to necessarily answer that, it's just something to think about.
Yeah, that would be a great thing to look into, and I think those phone calls are kind of a great example of why we were not able to capture a lot of this when we were trying to do like report generation that we've had really great success doing for other research projects. When we were looking through the charts manually, we were seeing a lot of nursing notes that said patient uncomfortable, unable to void, straight catheter was used, and that wasn't documented anywhere else. And I think a lot of these too might have even been in chats to the residents saying, they have this bladder scan, they're unable to void, should I do anything about it? And so that really presents a challenge of knowing how frequent of a problem this is. Thank you.
So I came from Massachusetts. Congratulations, Dr. Schneider. Great talk. Your answers are very well. Now, there's a couple of lessons to be learned. The ground truth is important, so this is why AI technology can give you wrong information. We have gone with what that we told you, you would have had a victory lab that Chan School of Medicine has better urinary retention than anybody else. But you didn't, and so I want to congratulate you for being, have the true integrity of a investigator going and doing it manually. You're a fourth-year student, and based on your calculation, you have 600 cases a year, right? Approximately. So you have enough time to do a prospective case at least 200 cases, prospectively standardized, no 40, have everybody void, check, everybody get a bladder scan, and you can probably answer your own question rather than trying to go back and look at all the various things that are not standardized, and it's hard to interpret. So I would recommend you do that and get a third year to go with it.
Thank you. Yeah, that's a great point. I think we were hoping that this would kind of set the grounds for doing something that's prospective. I think the point about AI and technology and research is really interesting. Epic reporting has been really useful for us in a lot of other research questions, but as you can see in certain research questions, it falls flat. And I hope that in the future too, there are some promises of technology or AI that's better at reading narrative notes. So that could be something in the future that would be helpful to this problem. If you're able to query patient charts, not only for the problem list diagnosis, but for phrases that were in narrative notes as well.
Mayor?
Yes, sir.
How many of those 4 patients you've encountered in 30 days of surgery?
I believe all of the 100 patients that we manually reviewed their charts, all 6 of those were within their hospital stay. So before that they went home, they had to receive a catheter because they were unable to void.
Thank you.
Thank you.
so that was really good. So a couple of side notes I would probably say, since you're going to probably go to surgery, right?
Hopefully,
That is,
yes.
there you go. Is as you're seeing your patients in your resident training, consider what is their post-op pain, because what you're told or what the notes say may not actually reflect the patient's condition, right? And that may influence in the future your assessment and your progress toward treating people with CAP in order to decrease form. It's sort of the whole emphasis of our research, right? How can we apply what we're doing today in the future for the patient benefit? Great job. Great job.
Definitely, that's an excellent point. Thank you.
Thank you.
Okay, so, you have another question? Yeah.
All of the presenters would meet up at the front of the room. We're going to get a picture of you with the moderators.
Yeah, we're going to announce the results of the 2023 Annual Research Scholarship Competition. let's take some photos.
Dixon in the middle. Dixon in the middle. And then how many presenters do we get? 6? 5. Okay, so we'll put, let's put you over here. Put you on there. And, you're tall. Right back there. Perfect. Sorry, you're not so tall. Oh, it's okay. Okay, there. Slide down just a little bit. Do I have symmetry? Switch Tony, you're an anchor. There you go. Okay. Okay, we ready? 1, 2, 3. 1, 2, 3, and looks good. Thank you, Craig. Going back to you.
All right, you guys stay up here because we have, it's going to be more. We're going to get our honorable mention awards, and the first honorable mention award is to Andrew Gordon for the research on cannulation strategies for the oxyrad, VV, ECMO, and end-stage lung disease. Thank you very much. The next honorable mention award is Rachel Snyder, evaluation of closed-top urinary retention. Third place is Hamza Ashfaq. Cost comparison, endovascular versus open surgical revascularization and popliteal artery occlusive disease. Third place award comes not only with that certificate, but you get a $200 check that you can frame. I don't have the money right now, I think you're good. Okay, second place award, it's $300, and it goes to Nicholas Demas for research Popliteal annually. And I think that leaves one standing. First prize, first place, and $1,000 goes to Ivan Rodriguez for whole blood resuscitation following liver transplant and transplantation. Well done. Congratulations, all of you. That was very, very nice and exciting. Good luck here in your future. That concludes our session.
Yeah, I looked over, I saw it, it's like, God damn. I don't know how to answer it. We're glad to have him. He's a working guy all the time. He's writing articles and doing research. Why don't you take a picture of the two of us talking? You have to send this to Holly. Oh, no, look at one more. You guys are smiling good. Thank you. I heard that Liam matched at UVA. What are you guys doing now? He's going to Maryland. We can get somebody to for us.